Hello, everyone. Good morning, good evening, good afternoon, wherever you have dialed in from. My name is Jason. I'm from Melbourne. I'm an immunologist and allergist. So, all right. So welcome to today's sessions on UCARE LevelUp. Today, we're going to talk about differential diagnosis of urticaria. And the title for today is Deep Down to the Differential Diagnosis of Urticaria, Autoinflammatory Disorders. What do we need to know? It's my pleasure today to welcome our faculty members, Professor Clive Grattan from the UK, Dr. Anne Pankow from Germany, and Professor Carolina Kraus from Germany as well. So the breakdown of the talk today, first of all, we'll talk about differential diagnosis of urticaria from the dermatology point of view, followed by differential diagnosis from a rheumatologist point of view, and finally, practical approach to manage autoinflammatory syndromes, and followed by Q&A. A crowd today. So before we start, I was hoping to announce our next webinar, which will take place 2 months from now on the 27th of September. So for the upcoming webinar, we'll be talking about when to suspect allergy in acute urticaria patients and when to suspect allergy in chronic urticaria patients and immediate contact reactions, including contact urticaria syndrome. We really appreciate you taking the time to provide any feedback regarding the webinar today. So this is a QR code. Let us welcome our first speaker, Professor Clive Grattan, who will talk about differential diagnosis of urticaria from the dermatology point of view.
Thank you very much. And it's a pleasure to be here in the webinar. I'm a dermatologist, and I'm going to speak about the differential diagnosis of urticaria from the dermatological viewpoint. These are my conflicts of interest. Questions at the beginning of this talk that I will address is, what is the difference between urticaria and urticarial? What conditions present with urticarial lesions? And does skin biopsy help in the diagnosis? And what other investigations may be relevant to diagnosis? Firstly, what is the difference between urticarial and urticaria? Urticarial is a description, so it's an adjective rather than a disease. In the same way as edematous is not the same as edema. Urticarial refers to skin lesions that look like wheals, but they're not. And there are many dermatoses with an urticarial appearance, but only one illness called urticaria. So it's an illness characterized by itchy wheals, angioedema, or both. And the dermatologist will be very familiar with the picture of urticaria, wheals in the top panel, angioedema in the bottom panel. Wheals are itchy, and angioedema is often uncomfortable and deep rather than itchy. And then there may be different patterns of wheals in the inducible urticarias, like these images showing dermographic urticaria, cholinergic urticaria in the middle, cold urticaria on the right, and delayed pressure urticaria at the bottom. The differential diagnosis of urticaria is well summarized in this figure from the international consensus published in 2022. At the top, we have the presentation with wheals or angioedema. On the side, we see history, and then the diagnostic test that we may do to reach a diagnosis. And then at the bottom are the different mediators that may be involved. So it is very important that we try to separate patients presenting with urticarial rash into these different subtypes. So for instance, if we look at the side with mainly wheals, but some angioedema, we need to know, is there any unexplained fever? And if there is, we think of autoinflammatory disease. Is the wheal duration more than 24 hours? If it is, we think of vasculitis. And are the symptoms inducible with provocation tests? I'm going to focus more on the urticarial lesions than urticaria today, including acquired and hereditary autoinflammatory disease and urticarial vasculitis. But there are other conditions which present with urticarial rash, which I will show you. The main differences between urticaria and urticarial conditions are summarized in this table. A very important question is, how long does the lesion last? For urticaria, it's hours. For spontaneous urticaria, maybe it's a day, perhaps a little bit longer, but 24 hours is the usual duration, or sometimes a lot less. Whereas inducible urticaria, it may be less than an hour. Whereas urticarial conditions, the lesion will last for days. So a very important starting point in history. Does the lesion itch? In urticaria, yes, usually intense. Urticarial conditions, it varies. It may be very itchy, but it may not be itchy. Does the lesion leave a mark? In urticaria, never. Urticarial, well, it may do, especially urticarial vasculitis. Does the lesion go scaly? In urticaria, never. In urticarial conditions, like for instance the acute presentation of contact dermatitis, yes, the skin may go dry and scaly afterwards. Is there angioedema in urticaria, particularly spontaneous urticaria? It's common. But in urticarial conditions, it's rare. Does the patient have a fever? In urticaria, never. But in urticarial dermatoses, sometimes. Is the patient unwell with arthralgia? Well, yes, in some severe types of common spontaneous urticaria, you may get systemic complaints, but it's rare. Whereas in urticarial rashes, for instance, autoinflammatory and urticarial vasculitis, it may be a key feature. Does skin biopsy help? Well, yes and no, because its clinico-pathological correlation is essential for the diagnosis of urticarial lesions. An urticaria is a clinical diagnosis made on the history and examination and the images a patient may provide. So how can skin biopsy help? In routine histology, you may see a dermal hypersensitivity reaction in urticaria and papular urticaria with eosinophils and maybe neutrophils. In dermatitis, epidermal spongiosis is a feature. In urticarial vasculitis, you will see features of vasculitis of small blood vessels. In urticaria pigmentosa, there will be increased mast cell numbers. In pemphigoid, there will be blistering with dermal edema and often eosinophils. In autoinflammatory disease, there will be a neutrophilic urticarial dermatosis picture. And we'll look at all of these. Immunofluorescence may be valuable as well. For instance, the linear band of the Mason membrane zone in pemphigoid and vessel wall immunoglobulins, particularly IgG and IgA, with C3 in urticarial vasculitis. So, here are some dermatoses that may be urticarial. Insect bites, giving papular urticaria. Acute dermatitis, which can be a contact allergic dermatitis and sometimes atopic eczema. Urticaria pigmentosa, Darier's sign, in cutaneous mastocytosis, immunobullous from monitory pemphigoid, very occasional dermatitis attitiformis may look urticarial. Autoinflammatory syndromes, CAPS, 5-PAR-associated periodic syndrome, or Schnitzer syndrome, the genetic and acquired autoinflammatory syndromes, and rare dermatoses like Sweet syndrome, Wells syndrome, connective tissue disorders, and infections, such as the prodromal rash in viral hepatitis and COVID-19, which have been described. And of course, urticarial vasculitis, which may be normo and hypocomplementemic. Let's go for some examples. This is papular urticaria. Lots of little urticarial papules with a tiny pinpoint of serum in the center of them. And if a biopsy was taken, and this is not usually necessary, there will be a dermal hypersensitivity reaction. And this may have eosinophils, neutrophils, lymphocytes as shown. But further investigations none, because it is a clinical diagnosis. Acute dermatitis, as illustrated with these very dematous eyelids. But if you look closely, you'll see that they're oozing. There is serum on the surface, and the epidermis has been affected. So here the histopathology is epidermal as well as dermal, with spongiosis and baby parakeratosis. Further investigations in this context would be patch testing for contact allergic dermatitis, testing for IgE sensitization in atopic dermatitis. In urticaria pigmentosa, it is very common that the individual lesions, the papules, or the macules will swell with edema when they're rubbed. And here's an example in an infant. Darier's sign is a very valuable sign of urticaria pigmentosa in children, but it may be positive in adults too. If you suspect urticaria pigmentosa, you would consider a biopsy in all adults and some children when it's important. And here you see large numbers of mast cells in the H&E sections. But when they're stained with special stains, here for acetate esterase, then the number of mast cells throughout the epidermis is revealed very clearly. So further investigations for a patient with urticaria pigmentosa, also known as maculopapular cutaneous mastocytosis in the modern classification, would be blood tryptase. Is there evidence of systemic disease? KIT mutations, particularly the common D816V KIT mutation, which can be done in blood and bone marrow and skin with the correct technology, and this may lead on to bone marrow biopsy, looking for evidence of systemic mastocytosis. Let's look at immunobullous disorders, pemphigoid. Here's a picture of pre-bullous pemphigoid. You can see the edema, but the blisters aren't obvious. But a biopsy will show the blister if the biopsy is taken from the edge or the subepidermal split with edema and eosinophils. And immunofluorescence can show the linear IgG and C3 at basement membrane cells. So further investigations for this would include direct and maybe indirect immunofluorescence on serum to look for evidence of these antibodies. Autoinflammatory disease. This will be covered in much more detail later, but just as an example of a hereditary autoinflammatory disease, Muckle-Wells syndrome, with red patches, which are probably not itchy, but the individual will be unwell. And histopathology is not specific, but will often show diffuse neutrophils, very little edema, and no vasculitis, but the neutrophils may cluster around the appendages. Further investigations for this scope of patients would be looking maybe for NLRP3 genotyping for cats, C-reactive protein for evidence of inflammation, ferritin if you suspect adult onset Still's disease, and electrophoresis looking for an IgM paraprotein if you suspect Schnitzler syndrome. And some words about urticaria vasculitis. You may suspect it clinically from dusky appearance and from rather prolonged wheals. And pathologically, the inflammation is centered on the blood vessels, with maybe neutrophils, leukocyte aplasia, fibrin within the small blood vessels and within the wall, and maybe some red cell leakage. So the diagnosis of urticaria vasculitis does hinge on seeing histopathological features of vasculitis on lesional skin biopsy. You would want to do complement studies, autoantibodies, look for chronic infections like hepatitis, HIV, look at the drugs the patient may be on, look for malignancy with simple questions and maybe some screening tests. Now there are subtypes of urticaria vasculitis. The commonest is the normocomplementemic variant, NUV, and then hypercomplementemic variant, which is HUV, and also the hypocomplementemic urticaria vasculitis syndrome, known as HUVs. But the normocomplementemic variant is the most common and the mildest form, affecting about 80% of patients, usually without organ involvement. So hypocomplementemic urticaria vasculitis tends to be more severe. HUV and HUVs could be part of a disease continuum ranging from isolated vasculitic lesions with low complement to a more systemic disease with multi-organ involvement and anti-C1q antibodies. Hypocomplementemia is often associated with long duration, systemic symptoms, underlying disease such as lupus erythematosus, inflammation of the skin characterized by diffuse neutrophil-rich infiltrates. And anti-C1q antibodies are not specific to HUVs. Just a little bit more about HUVs before I close. HUVs is the most severe subtype, identified in about 5% of patients with urticaria vasculitis of more than 6 months duration. And clinical features include biopsy-proven vasculitis, arthralgia, uveitis episcleritis, current abdominal symptoms of pain, vomiting, glomerulonephritis, presenting with microscopic hematuria, proteinuria, cough and dyspnea, occasionally COPD in smokers, lymphadenopathy, decreased C1q, and the presence of anti-C1q autoantibodies. But not all systemic features are required to make a diagnosis, and some neurological manifestations may occur. So in summary, why does the correct diagnosis matter? Well, appropriate investigation, appropriate management, treatment of causes where possible, avoidance of triggers, medication. Urticaria rashes will probably not respond well to antihistamines or indeed omalizumab. Prognosis. What's the future? Prediction of inheritance in hereditary autoinflammatory syndromes and giving the patient advice and information. So thank you for listening, and I will close so the next presentation can take place.
Thank you very much. Thank you for the fantastic talk on differential diagnosis of urticaria from a dermatologist's point of view. Let's move on to the second topic today. Let's welcome Dr. Anne Pankow to talk about differential diagnosis of urticaria from a rheumatologist's point of view. Thanks, Anne.
Hi, everyone. Let me just share. So welcome to my part of the lecture. Thank you very much for the invitation. Yes, my name is Anne Pankow, and I'm a doctor for rheumatology at the Charité in Berlin. And I'm the head of the special consultation for autoinflammatory rheumatological diseases. So These are my conflict of interest, but they don't have any impact of my talk today. So what I want to discuss with you today are the autoinflammatory diseases in which an urticarial skin phenomenon also plays a key role. And I would like to focus on one disease in particular, which I will discuss using the example of one patient case, the case of Mrs. U. And after this, I will talk about the disease, the adult onset still disease, and after this, a small summary. When we talk about autoinflammatory diseases in rheumatology, we mean various disease patterns that are characterized by generalized inflammatory episodes and certain symptoms. It is important that these diseases do not have any autoantibodies. If they have autoantibodies, it's not an autoinflammatory disease. So we have red flags where we should think of an autoinflammatory disease. And these are intermittent fever, positive family history, childhood onset, peritonitis and pleuritis, arthralgia and myalgia, skin lesion, for example, urticarial, and high inflammation levels in the blood. So we take CRP and serum amyloid A, which is elevated. First of all, I want to talk about problems in patients with autoinflammatory diseases. Most of the autoinflammatory diseases are very, very rare diseases. So we have the problem that the patients are often diagnosed very, very late. So I'm very happy that I can talk here today about this issue, that we can, work on this problem. So I have here one study. In this study, 37 departments were asked to rate the time from the start of first symptoms to the final diagnosis for the different diseases. And as you can see here, we talk today about the adult onset still disease, ROSD. There it's about 1 year, but if we look at the CAPS or TRAPS, it's very, very rare. And there we have 5 or 6 years until the patients receive their diagnosis. But not only the time until diagnosis is challenging for the patients suffer from socioeconomic burden, they suffer from emotional factors like the guilt of transmitting a genetic disease or social isolation and the feeling of being different, and with limited trust and support of health system. And also long-term effects, because these diseases are chronic diseases. So they have to take medication, most of them for their whole life. And then I come to my case today. So this case is Mrs. Yu. She presented in the outpatient clinic for the first time 3 years ago. She was 19 years old and she came with this skin lesion. So for me, I'm not a dermatologist, but for me, it looked like a bit like urticarial skin lesion. And she described it was not itchy and it was transient. So I thought perhaps it's urticaria. But after this, I asked her if she has any symptoms or more symptoms. And then she described, she has a sore throat, she has arthralgias, also intermittent fever, 40 degrees, night sweats, and she has a white loss. And in the blood, we saw CRP more than 300 and ESR more than 80 millimeter per hour and ferritin elevation. In the next picture, you can see her hands, and there you can see on the right hand swollen joints. They were swollen, they were red, they were warm, and they were very it was painful for her when I touched her hand. Then we did an ultrasound of her spleen, and we saw a splenomegaly, very prominent. So if we resum all these symptoms, we have the fever, we have the white loss, we have the night sweats, we have the exanthema, the arthralgias, the splenomegaly, the pleural effusion. I didn't talk about this, but she has also pleural effusion. And we have the elevated CRP, ESR, and ferritin. The problem with autoinflammatory diseases is that these diseases are periodic. They have periodic fever syndromes. And that's why and I wanted to show you how we do this, because often if they are here, when I see them, they are like, no, I'm fine now. But in between, when we don't see each other, they report the fever and the symptoms. That's why I give them a fever diary. And this is an exemplar of a fever diary. So I ask them to fill in if they feel bad, if they have symptoms, and there we ask for fever, for abdominal pain, for diarrhea, for headache, for thoracic pain, for lymph nodes, for pain in the joints, and so on. And we asked them if they took medication against the pain. So now, if we see all this, the symptoms of our Mrs. Yu, I thought, okay, it's very intuitive that it's adult onset still disease. But first of all, because this disease is an exclusion disease, we had to make the exclusion of malignancy and of an infectious causes. So we did this, and after this, we could confirm the diagnosis, and we gave an IL-1 antagonist, which quickly relieved her symptoms. So let me talk about the adult onset still disease. It's an autoinflammatory disease, and two parts are involved. It's the innate immune system with the NK cells, the complement factors, the IL-1 and IL-18, and with the acquired immune system with the T cells and the B cells, and there the system of IL-6 and TNF-alpha is involved. We have typical symptoms, more or less the same symptoms like our Mrs. Yu. It's pain in the joints, we have the sore throat, high fever, and a rash. So this disease is also, we can also observe in children. And some years ago, there we call it systemic juvenile idiopathic arthritis. And some years ago, we thought these are two different diseases. But nowadays, we think it's more a continuum from systemic juvenile idiopathic arthritis to the ISD in the adulthood. Here, I want you to show the Yamaguchi classification criteria. So we have major and minor classification criteria. We have as major the fever of at least 39 degrees, arthralgia or arthritis. We have the non-pruritic salmon-colored rash, and we have the leukocytosis. As a minor, we have the sore throat, the lymphadenopathy, hepatomegaly or splenomegaly, abnormal liver function tests, and negative tests for RF or ANAS. So let me talk about the management of the ISD. First of all, we have to separate the mild activity, the chronic articular type, and the moderate to severe systemic activity. If we have a mild activity, we can treat the patients with NSAIDs or low-dose glucocorticoids. And if it's chronic, we can use like MTX, methotrexate. If it's more chronic articular type, we can use low-dose glucocorticoids, we can use MTX, or if it's refractory, we can use IL-1 inhibitor. If it's moderate or severe, like our patient, Mrs. U, we start high-dose glucocorticoids, and if they don't respond or it's coming again and again, we can take IL-1 inhibitor. There we have two substances, it's anakinra or canakinumab. So if we go back to our Mrs. Yu, we gave her anakinra, an IL-1 antagonist, and I see her very often now, and she's fine, she's happy, no more symptoms, and she always wanted to be an educator, and now she's working in the kindergarten, and yeah, is a very happy and without any symptoms anymore. Thank you for the attention.
Thank you so much for the fantastic talk. I'm sure the audience have learned a lot from the first two speakers. Let's move on to the last speaker today. So Professor Caroline Krause, we're going to talk about practical approach to manage autoinflammatory syndromes. Thank you.
Thanks a lot for the organizers inviting me today. I'm very happy to talk to you about practical approaches how to manage autoinflammatory syndromes. So these are my conflicts of interest. And I will talk today about also a clinical case I will present you, which has quite a lot of similarities as the one Anne just nicely showed. I will then focus on management of our autoinflammatory patients, what treatment options do we have to offer, and what key challenges and unmet needs these diseases still have. So let's start with a case. Again, it's a female case, slightly older. So this is a female lady, 59 years old. A couple of years ago, she first presented to our outpatient clinics at the Department of Dermatology and Allergy in Berlin Charité. And she complained about wheals, which were there for chronic recurrent urticaria wheals for about 4 years. They appeared daily, in particular in the evening. So when we saw her first in the morning, there was not much to be seen. However, she said, you should see me beginning on the afternoon. It's getting worse and worse. They were just slightly itchy. And this is a typical picture of her back. You can see here on the right side. So she had already undergone search for underlying causes. There was nothing to be found in terms of intolerance, infections, autoimmune diseases. Nothing was wrong with her, and she was completely unresponsive to antihistamines. So this was still before the anti-IgE era. So this she hadn't tried, but antihistamines didn't do anything. So going deeper into her history, she said, well, the wheals usually took about 2 hours, sometimes also longer. Difficult to really tell for her, but mostly they were rather 2 to 3 hours. No angioedema at all. She never complained of any swollen lips or anything else. However, she was complaining about joint and severe bone pain, in particular around her knees and the clavicular region. Also, she was always ill. So she was working as a teacher, and she said, well, I have the feeling I can't work that much anymore as I used to, and it's getting me more and more tired working with my children. Evening chills, and every 1 to 3 weeks she complained about fever episodes. So moving further into diagnostic tests, we did a skin biopsy in her case, and here you can see on the left-hand side, already pointed out by Clive, these perivascular neutrophilic infiltrates, which can be seen here nicely with an anti-myeloperoxidase stain, where you can see these red spots here around the vessels. She had elevated inflammatory markers, CRP, serum amyloid A, and also in her serum electrophoresis, you can see here this peak, which was then shown upon immune fixation to show a monoclonal band for IgM. So to sum up, she had a diagnosis of Schnitzler syndrome. So Schnitzler syndrome, it is diagnosed just clinically. There are 2 major criteria. This is first the chronic urticarial exanthema, and then second, the paraprotein. Both major signs have to be there. Usually it's of the IgM class in about 90 to 95% of cases, rarely also IgG. However, if you have an IgG variant, you need to be more careful. Is this really Schnitzler syndrome or the IgG clone, which is, as you probably all know, quite frequent in elderly people, can also be related to something else. Then we need to have at least 2 minor criteria if it's an IgM gammopathy: recurrent fever, osteosclerosis, CRP elevation and or leukocytosis, and the neutrophil-rich dermal infiltrate, which can be seen here again in this H&E staining with these dense neutrophilic infiltrates. And so our female patient had the IgM variant, the exanthema, the fever, also the osteosclerosis, which could be proved also on MRI imaging, and of course also the other 2 findings with the elevated inflammation markers in the dermal infiltrate. So how do we manage these patients? We already heard about options. Let me just start. Why is this very important? So many of these autoinflammatory diseases, they're very rare diseases. Anne mentioned that there is a huge delay in diagnosis for many of these patients, and therefore, at least decades ago, many patients suffered from long-term complications if they were not treated by time. These are bone deformities, for example, in CAPS patients, opticus atrophy, neurological symptoms, growth retardation, amyloidosis, osteoporosis due to the severe inflammation. Hearing loss is something we in particular observe in the genetic CAPS disorder, and lymphoma. This is something that may present in patients with Schnitzler syndrome, because 10 to 15% of these patients develop an lymphoproliferative disease, and most often Waldenström's disease, due to this monoclonal gammopathy. So what are the aims? First of all, improve the symptoms, the quality of life, prevent further organ damage, and stop a progressive disease. And this is usually done by controlling the inflammation. And how is this done? So as we know, most of these diseases are in particular mediated via the inflammasome. The inflammasome is an intracellular multiprotein complex which mediates the two cytokines IL-1 beta and IL-1 into their active forms. And if we have a mutation, for example, here in this genetic disorder CAPS in NLRP3, in this protein here, then we have a lot of IL-1 beta, and in addition also IL-18, which is processed, and then a lot of IL-1 beta mediated inflammation. We know that this is not only true for CAPS, but also presents in other diseases such as gout, Alzheimer's, but also very common diseases, cardiovascular diseases, and also dermatologic conditions such as contact dermatitis. So the available treatments, anti-IL-1 blockers, already mentioned briefly. We have 3 IL-1 blockers. 2 of them are currently marketed in Europe, and in the US we also have a third one, rilonacept. Let me start with the one anakinra. This is an IL-1 receptor antagonist, has the shortest half-life of 4 hours. It blocks both IL-1 alpha and beta, and it's licensed for CAPS patients and also for rheumatoid arthritis, and now also can be applied in FMF patients. Then we have rilonacept. This is a dimeric glycoprotein, a fusion protein, also blocks IL-1 beta and alpha. And however, currently it's only available in the US for adults and children all aged over 12 years in CAPS patients. And then we have canakinumab, the selective anti-IL-1 beta specific monoclonal antibody with the longest half-life of about 4 weeks. And this specifically blocks IL-1 beta and is licensed for CAPS, already in small children, for severe forms of gout, for Still's disease, and also for other periodic fever syndromes such as FMF, mevalonate kinase disease, and TRAPS, all very rare diseases. So the first proof of concept that this is really effective in one of these rare diseases in CAPS patients came from this small study, only 18 patients, both children and adults were included, placebo-controlled, received anakinra treatment, and within days you could see a clinical and also laboratory improvement in these patients, very similar what Annes described with her Still's disease patient. So this is also true for Schnitzler syndrome. For Schnitzler syndrome, this is a French multi-center study with 42 patients of this rare disease, showing that with anakinra treatment, patients in terms of rash, pain, and fever all improved a lot with anti-IL-1 receptor antagonist treatment, and also their inflammation markers went down. Interestingly, their IgM levels from the monoclonal gammopathy, they were stable or went up over time. So there was no change due to the introduction of treatment. Then we did a study in Berlin and included 20 patients with Schnitzler syndrome in Berlin and other centers in Germany with Schnitzler syndrome, also placebo-controlled study to look for efficacy and safety of canakinumab, the IL-1 beta monoclonal antibody. And as you can see here, this is the placebo-controlled part. So with canakinumab treatment, you see a very good clinical effects. So the physician global assessment, so the clinical disease activity goes down here in canakinumab treated patients, but nothing happens with placebo. And also patient-reported assessment of disease activity improves a lot with canakinumab. This is also seen for inflammatory markers and quality of life, which improved as well. And also over long-term assessment. So these patients received canakinumab for a long period, so for almost 4 years. And you can see here a stable disease over this period. However, it is still not licensed for this disease, which is really a problem for many of these rare diseases where we have nothing to offer apart from clinical trials. Here we did another trial with anti-IL-6 treatment. Anne already said anti-IL-6 or IL-6 also plays a role more from the adaptive immune system, in particular in Still's disease. And there were also reports that it might be helpful in Schnitzler patients. And here it improved also the clinical symptoms. However, after some weeks here, week 28, you can see disease activity goes back. So this was shown in most patients, unfortunately. So therefore, most patients had to stop anti-IL-6 treatment here, at least in Schnitzler syndrome. There are further treatment options, a lot of immunosuppressives that were tried, other also biologics. However, as already mentioned, nothing is approved so far, so we are always in the off-label treatment. And treatment monitoring, what is important, what should we do, what should we look at? So first of all, I already mentioned for the clinical trial, physician global assessment. This is what we use for our trial, and this is also what we use at our clinics for our daily routine. It is a simple assessment tool. It's not validated yet for these rare diseases. Often it is very difficult to validate these assessment tools. However, it summarizes the 5 most critical clinical symptoms: the rash, fatigue, fever, chills, myalgia, arthralgia, bone pain. And there you have a good idea, if you use this simple instrument, whether a patient improves or not with a certain treatment. And this is routinely used over time to monitor disease activity. Which lab parameters should you apply? So before treatment, it is important, if you're going for an anti-cytokine targeted therapy, to exclude chronic infections such as hepatitis, HIV, tuberculosis. Then we always do routine chemistry, differential blood count, inflammatory markers, besides CRP and SAA levels, also S100 proteins. A8-9 is the most commonly used variant, is very helpful because this can already show subclinical inflammation in patients. Urine analysis is important to look for amyloidosis or rule it out. And if we have suspicion of Schnitzler syndrome, always do, besides serum electrophoresis, as Clive already mentioned, immune fixation and quantitative immunoglobulins. Beta-2 microglobulin can be used to monitor for lymphoma. It's a good marker for lymphoma. So if this goes up, important to also work together with your local hematologist. Then genetic tests, of course, if you suspect early onset of disease, CAPS and other hereditary diseases. During the treatment, every 3 to 6 months, again, routine assessments, inflammatory markers, urine analysis, and quantitative immunoglobulins, and in case of Schnitzlers, again, the microglobulin. So it is always a good idea to work together with other specialties. In Berlin, we have an autoinflammation reference center, and we have a very nice situation where we can just ask our colleagues, Anne, and also the colleagues from the pediatrics departments, the pediatric rheumatologists, but also hematologists in particular, if we have patients with Schnitzler syndrome, ENT specialists, if it's, for example, CAPS patients with hearing loss, neurologists. A lot of patients have also neurologic problems in CAPS patients, TRAPS patients, but also, for example, polyneuropathy, which can often be seen in Schnitzler syndrome as well. So what does the future hold? Is it only anti-IL-1 what we can offer, or other cytokine targeted therapies? Well, there are certain attempts to directly block the inflammasome. And so this could have potential advantages, such as an oral administration, if we think about small molecules, lower costs, and be maybe even more specific if we target the NLRP3 directly and not the downstream cytokines, and maybe also prevent some of the side effects we sometimes see with anti-IL-1 blockade. And so that this already works was shown first time in 2015 by the study, which used a so-called small molecule, which specifically inhibits the NLRP3 inflammasome, also known as MCC950. And this was shown to be effective in mice, which held the CAPS mutation. So here it could taper down the inflammation very nicely. And so to date, there are a couple of very promising NLRP3 specific small molecules. And 2 studies, I just looked at clinicaltrial.gov yesterday and found one here in the US, which is going to recruit patients with this specific NAL3 inflammasome inhibitor, and another one here, which just, so this is a phase 2 study, and the one here completed is another NAL3 specific inhibitor, which was done in Australia, in Adelaide, and was very successful. It's a phase 1 study in CAPS patients. So there is hope that we might get further drugs, and maybe also for cases where we do not have anything approved yet. So key learnings and challenges. So symptoms: chronic urticaria rash and systemic manifestation. Then you should think about autoinflammation. For the diagnosis, it's important to look into a differential blood count, do inflammation markers, think about genetic tests, or if it's later onset adults, immune fixation. Also think about ferritin levels if it's an acute inflammation with a lot of joint involvement. Do a skin biopsy. Therapy, we have good anti-IL-1 blockers, also anti-IL-6 blockers. And challenges, so symptoms can often be unspecific. In particular, fever is quite common symptom, arthralgia. Sometimes not all symptoms are complete. Sometimes there's the arthralgia missing, or the fever is missing, and then it takes even longer to diagnose such a patient. Exclusion of other diseases is important in the diagnosis. Lack of biomarkers is often a problem, and as mentioned, the non-existence of validated assessment tools, such as to monitor disease activity for many of these very rare diseases. And therapy-wise, as showed, for example, for Schnitzler syndrome, but also for other rare diseases, also urticarial vasculitis, this applies for, it is always off-label use. And we only have few data from randomized controlled trials. Therefore, it's most important to increase awareness and also to work together with in an interdisciplinary approach with other disciplines. And with this, I would like to thank you all for your attention.
Thank you so much for the fantastic talk. I'm sure the audience today have learned so much from our three phenomenal speakers tonight. We have some time to go through a few questions. There's a question who asks about, can a patient have urticaria and urticarial vasculitis together? The treatment is treating the vasculitis and urticaria as separate diseases. Anyone, any of our expert panel would like to offer an answer to this?
Let me contribute here. Urticaria is a specific illness. Urticarial vasculitis is a specific illness which is defined by clinical presentation and seeing vasculitis on skin biopsy. It is very rare, but sometimes a patient with chronic urticaria may at a later stage show features of maybe urticarial vasculitis. So they're not completely distinct, and sometimes the pathologist will struggle to separate the biopsy of active spontaneous urticaria from non-urticarial vasculitis. In other words, the normal complementemic urticarial vasculitis presentation. So it's quite a long answer, but no, I think it would not be realistic to have a patient with both illnesses at the same time.
Thank you for that. Let's go to the next questions. I think this is a question directed for Anne. Would you prefer anakinra or canakinumab in adult onset Still's disease?
Yeah, this is more an economic question because anakinra is much more cheaper than canakinumab, much more cheaper. So that's why I would more often start with anakinra, and then not working, I would switch to canakinumab. And another topic is that children, our pediatric colleagues, more often use canakinumab because it's only you have to do the injection only once a month, and anakinra every day. And that's why for the children it's better to use the canakinumab because it's only one injection in 1 month for them.
So let's move on to the one question. When do we include serum electrophoresis, serum amyloid in the workup of patients presenting with urticaria rashes and other symptoms pointing to autoinflammatory disorders? Maybe we can get Caroline to answer this, please. Yeah.
Yes, sure. So thank you for the question. So serum electrophoresis, we always do in our diagnostic workup if it's an adult patient. So in children, we wouldn't go for it. Yeah. So Schnitzler syndrome, this is where you should think about it. And the usual age of onset is around 50 years. So in the more elderly people, we would always go for serum electrophoresis, but do not forget to also go for immune fixation, because only then you can be sure that you have a monoclonal gammopathy. And for the serum amyloid A, I mean, it depends a bit what kind of lab you have. If it's easy for you to measure and your lab does it as a routine measure, I would always go for it. However, if it's you only have CRP available, then just start with CRP. So go for the easy things first, and this would definitely be a differential blood count and CRP levels. And if this is both high, then you could still think about it. I mean, it is important if you have a suspicion of amyloidosis, but then you would also need to involve a nephrologist or at least some specialists in this field. And so for starting, it's always good to start with differential blood count and CRP.
Thank you very much again to our three speakers tonight for your hard work in presenting the talk today. So let me take this opportunity to announce our next webinar sessions, which will take place in September. For those who have missed this announcement in the earlier part of the presentation, the next session will take place on the 27th of September. We'll be talking about the usual suspect in Urticaria, and we'll also cover immediate contact reactions in contact urticaria syndrome. And before we end the session tonight, may I please ask everyone to complete a survey by taking a UR code. So really appreciate your feedback on that. So with that, we'll close the session tonight. So once again, huge applause to our speakers tonight, and we'll see you next time.